All right, so let's pick up with cardiac tamponade. Just by way of notification, we are being recorded. So cardiac tamponade is basically when fluid begins to accumulate around the or on the inside of the outermost layer of the heart, and then on the outside of the epicardium. Okay, the pericardial sac is a protective mechanism for the heart. It's tough, it's fibrous. If we took one out, it would not stretch. One of the things that I'm hoping to do, and you guys may get to do it next semester as part of 360, is that we've been able to order a number of preserved pig hearts, and we're going to dissect those. And so by pulling off the pericardium, then you will be able to actually feel what it's like. The other thing, and I picked this up from a colleague in Kansas, is that we'll take glow stick liquid, break it, activate it, draw it up into a syringe, and we'll squirt it, we'll inject it into the different coronary arteries, and then turn the lights off so that you can see kind of how those arteries are spread out and what comes into as far as that process. But again, the pericardium is very fibrous, very, very tough. It does not stretch at all. So if we have a patient that has a pericardial tamponade, and keep in mind that a patient can develop pericardial tamponade either from trauma or from a cardiac issue, we begin to get fluid. Now that fluid can be serous fluid, it can be, if it's an infection, it can be pus. If it's trauma, it can be blood, or it can be a combination of all of the above. And generally what happens now is that it begins to squeeze in on the heart. A similar thing happens. I realize we're not in trauma, but if you'll think about it, Bella, similar thing happens when we have a brain bleed, an epidural brain bleed, in the fact that it forms on the outside of the dura mater. Also, very tough, very fibrous, does not stretch, and now it pushes the brain inward. So the tissue of the heart will actually begin to be pushed in, or as the technical medical term is, it will start to get squished, okay? Now, when this squishing occurs, basically what's happening now is that it reduces our preload. My question for you, ladies and gentlemen, how does it do that? Why is preload reduced in a pericardial tamponade? Remember, preload is simply identified as, or defined as, the amount of blood that is delivered and brought into the heart itself. If this is our heart, let's do it this way. If this is our heart, and we've got bleeding up here on the top, Aziz, and now that bleeding or that fluid is decreasing the volume of one or more of the chambers, now we're going to have a problem. Let me ask you a question. What chamber is the most common chamber affected in pericardial tamponade? So you got 1 out of 4 chances of being right.
Left ventricle.
So Devin says left ventricle. Anybody else with something different? Rahana, what did you say? You've got a sneaky smile on your face. Okay, got a right ventricle. Can I get a right atrium or a left atrium? Actually, and it pains me to say this.
Let's go. I'm 3 for 3. Let's go.
Devin is right. So why is it that it's the left ventricle that is most often affected? 75% of the heart, actually.
Let's go.
So yeah, you're exactly right. Now, Devin, remember, even a blind dog finds a bone every now and then, okay?
You know.
So when we're looking at this, yeah, so it's going to be the left ventricle that's going to be impacted. So not only are we decreasing preload, but we're also decreasing cardiac output that's going to come into play here. Now, when we're looking at this, keep in mind that pericardial tamponade can be chronic or acute. All right. And so if it's trauma, it's generally going to be an acute onset. It's going to happen really, really quickly. If it is chronic, it could be potentially from any number of reasons, up to and including something as simple as an infection located within the heart. And so this is one of the things that you want to kind of keep in mind in the back of your mind. A number of you guys are going to be working in the ER. A number of you guys are going to be working as community paramedics. Anytime a patient tells you that they've got some type of an infection in the heart, you should always assess them for dental care, okay? All right? Why? Why would what do our teeth have to do with our heart? Because there is a direct relationship.
Plaque.
Tell me more.
Bacteria lives in your gums. Whenever you get surgery, especially recent care, every time that you cut into those gums, you risk getting infections in your bloodstream.
Good, Lewis. Yeah, you're exactly right. Remember, the human mouth is the dirtiest mouth around, okay? If you have a choice of being bitten by a dog or by a human, always choose the dog, all right? And it's just like Lewis said, we've got lots and lots of bacteria in our mouth. And so if a patient has a problem with poor dental care, they have cavities, they have bleeding gums, they have all kinds of different problems, that bacteria can get into the bloodstream really, really quickly, just like what drug that we give to go to the heart really, really quickly. Aspirin. Same premise exists, okay? So again, when you're working in the ER, if you're working as a community paramedic, and a patient has got some type of an infection in the heart, assess them and find out about, because this may be where it is coming from. That can truly be life-threatening because it can lead to this condition of pericardial tamponade that's going to come in here. Now, what does your patient look like? Well, first of all, they're going to have trouble breathing, okay? Why? What's going to lead to their difficulty breathing? Yeah. So we have, in essence, even though the left ventricle, the muscle may be healthy, Aziz, and it wants to pump correctly, because of the compression, it's not able to pump correctly. Therefore, we have a mechanical onset of heart failure that's happening, Miriam. And so we begin to have the patients having difficulty breathing. Again, what is leading to that difficulty breathing? Yes. And so this is where we would see in here where it's talking about, let me get my little laser pointer here, orthopnea, okay? Orthopnea means what, Aziz? If I told you that your patient, let's say you're getting ready to take a transfer and I tell you your patient has severe orthopnea, what did I just tell you? Okay, that's fair. Anybody else? Yeah, so orthopnea is your breathing is dependent upon sitting upright. Ortho meaning movement. PNEA is your breathing. Okay, these patients are not going to lay down flat. Right. The other thing that you're going to want to assess with these particular patients out in the field, again, coming back to any patient that has a history of pulmonary edema or heart failure. What are you using to sleep on? How many pillows are you sleeping on? Remember on Thursday we talked about the fact that some of your patients will not have slept in a bed for a long time. Why? Because they have to sleep in the recliner. Their orthopnea is that bad that they've got to sleep sitting up. Why? Because otherwise the fluid, the crackles that you will hear in their lungs, often if they're really severe, you'll be able to hear them with no stethoscope. That tells you how critical that it could be, Bella. But definitely that would lead into there. The other thing that we're going to see is these patients are going to have a fast pulse, which is exactly what you would expect, but it's going to be weak. You're not going to feel it very strong. The thing that you're going to be looking at as far as if you suspect, and I'll give you a couple of other hallmark symptoms to look for in a second. But if you suspect that your patient has cardiac tamponade, compare your carotid pulse with a radial pulse. The radial pulse should be about 50% weaker than the carotid pulse. Why? Because of what they say about real estate: location, location, location. Your heart is right here, okay? It's pumping right here. This comes straight off of the aorta. And so the strength of that pulse, Devin, should be much stronger than what you would have down here in the case of cardiac tamponade. The other thing that we're going to look for here is look for JVDs. Now, what would be the problem? I thought we talked about the fact that it's the left ventricle that is most often affected, which would lead to pulmonary edema in the lungs. But we don't get JVDs from left ventricular failure. We get it from right ventricular failure. What's up with that? How? Say it again.
It's a complete closed system as well. So when it affects the right side of the heart, right at the sac that's covering most of the heart, so it's still going to affect it at least a little bit.
So yeah, we will probably have some indirect pressure that is put on the heart itself, or the right ventricle itself. But again, remember, cardiac tamponade is going to, if your patient is becoming symptomatic with cardiac tamponade, eventually the blood that is backing up into the lungs is also going to continue to back up, because at a certain point, Muna, the alveoli can only get so full. And now it begins to back on up into the right ventricle, which is where we would begin to see JVDs. Again, in severe right heart failure, whether it's from heart failure, whether it's from cardiac tamponade, make sure that you're assessing for JVDs. Make sure you're assessing for pedal edema. Unless cardiac tamponade is chronic, you're not going to see pedal edema in your patient, okay? So if it's a sudden onset from trauma, that's not going to be there, but you still need to assess it. And the other thing you want to do is press in on the lever and watch to see what happens with the jugular veins. You're going to begin to get a narrowed pulse pressure. Anytime, first of all, tell me, what does pulse pressure indicate? The pressure in what? What does pulse pressure indicate? Yep, cardiac output. So basically what we're seeing here is as the pulse pressure narrows, now our patient has less and less cardiac output. Now, let's review again. Now, don't mistake pulse pressure for MAP. They're two entirely separate measurements. They're both very important, okay? But with pulse pressure, how do we determine a pulse pressure? How do you know whether you have a narrowing or a widening pulse pressure? And doing what with them? So now remember, you're obtaining your pulse pressure by doing the math. So you've got a number. What is that number going to do if it's beginning to get narrow? Once you get your blood pressure, you're going to subtract systolic from diastolic, okay? You're going to wind up with a positive number. When you're doing that, again, like you said a while ago, you're going to take a lot of blood pressures, one at least every 5 minutes apart. If your patient is having a narrowing pulse pressure, that number will trend to getting smaller, the number between the systolic and diastolic, that number that you come up with. If it gets smaller, that's an indication of decreasing cardiac output and that your patient is going or in shock. Let me ask you a trauma question. Bella, if your pulse pressure is getting wider, which if you got a narrow pulse pressure, means the numbers are getting smaller. Pulse pressure getting wider, it means they're doing the opposite, they're getting larger. What's that mean? No, the narrowing pulse pressure means that you're not getting good cardiac output. Anybody have and guesses are welcome? A type of shock. With widening pulse pressures, we see this in head trauma. And so with widening pulse pressures, that means intracranial pressure is increasing. Remember, with head trauma, you're going to see a decrease in the heart rate because you're going to see these astronomical numbers over here as far as blood pressure. It is not unusual to see in head trauma blood pressure such as like 260 over 120. And you can watch that number begin to inch upward as the pressure in the brain begins to increase. So again, narrowing pulse pressure means decreased cardiac output, not good for our patient. Now, the other thing that we're going to see here is a condition that's known as pulsus paradoxus. Pulsus paradoxus is where your patient's blood pressure drops by 10 points or more when they take a breath in. So when we increase the pressure in the chest, now the patient's blood pressure drops. That's difficult to get unless you're going to do a manual blood pressure and you're watching the patient. The systolic blood pressure is what we're looking at here as far as dropping, Devin. All right, so pulsus paradoxus. Now, as we're looking at this, keep in mind that there's on the notes. Let me get on here. Okay, the other thing that we're going to hear, in particular, along with jugular vein distension, is that we're going to hear muffled heart tones. Now, how would you identify muffled heart tones? What do they sound like? Say it again. Far away. That's good. So you can't, when you're listening to these heart tones, they sound like they're way off in the distance. Okay. The way that you begin to identify now that you can to tell that a patient has muffled heart tones is like I've shared before. On all your patients and on each other, begin to regularly listen to breath sounds and heart tones on everybody that you have an opportunity so that you can identify this is what a normal heart tone as far as volume sounds like. Why do heart tones begin to get muffled?
So much fluid.
Go ahead.
What makes it dilation?
Dilation of what? No. Now remember, you're right. So we've got too much fluid that's surrounding the heart. When we listen to heart tones, what are we actually listening to?
The valves.
Yeah, so we're listening to those valves open and close against each other.
So if there's so much fluid when they open and close, you're just opening and closing against liquid. So that's why it's funny.
Yeah, so again, in particular, remember that most of the time it's going to be the left ventricle that's going to take the biggest brunt of cardiac tamponade. Again, why? Because it's 75% of the heart. So what you're actually going to be hearing, now we can't guarantee this because it's possible to have a tamponade on the posterior part of the heart or even just within the right or just over top of the right ventricle. But what you're actually listening to is the muffled sound of what? The tricuspid or the bicuspid valve? The bicuspid valve. The bicuspid valve. And again, that's not because there's a lot of fluid in the heart. There's no more fluid in the heart than what is supposed to be in there. As a matter of fact, there's actually less volume in the heart by way of blood because we've got this compression that's going on. And so that's what you're hearing is that muffled bicuspid heart tones. Basically, what we're going to do is that we're going to provide supportive care for our patient. At one point in time, let me back up. We'll talk about this, okay? What we're looking for is that we want to maintain an adequate blood pressure for our patient, okay? Now, the first thing that we're going to want to do, and this is something that I would encourage you to think about, would be consider. You don't always have to go with this, but consider the administration of a fluid bolus when appropriate anytime that you've got a patient with a low blood pressure. Again, the key words there is when appropriate. All right. We obviously in trauma, we don't want to flood our patient with fluid. Does a couple things. Number one, it washes out the clots. Number two, it washes out the red blood cells, and it can really mess up your patient's pH. But we want to get that pressure up. How does Starling's law now work in your favor as far as doing a non-surgical treatment for pericardial tamponade in the field? Okay, you're like 95% of the way there. Somebody else fill in the blank. Say it again so everybody can hear you.
If the blood pressure is higher, the pressure inside of the heart is higher with the fluid volume as well.
So let me edit one thing on your statement because you did a good job. It's not because the blood pressure is higher. The end result will be that the blood pressure will go higher. Devin.
Fluid going in is going to make it expand. And that's
Yeah, so two things that happen here when we give our patient a fluid bolus in cardiac tamponade. Number one, Starling's law says what?
the greater the stretch,
The greater the stretch, the better the contraction. The greater the snapback. The greater the snapback, also known as inotropy, the better our cardiac output is going to be. So when we give our patient a fluid bolus in here, Aziz, and that bolus of fluid gets into the heart, two things are going to happen. Number one, we're going to stretch the heart out even more, which because of inotropy, it's going to help to raise our pressure. Second thing that happens here, guys, is if this is as a result of trauma, when stretching the heart out, what's going to happen to the blood in between the pericardium and the endocardium? Yeah.
it's going to force it into the.
Y'all are right. Yeah, so it's going to literally force that out. Now, that's not a permanent solution. Basically, what we're doing is we're slowing down the dying process, okay? Long enough to get the patient to the hospital, all right? So, and again, in this situation, and this would hold true whether it is a pure cardiac issue from a disease process or from trauma. Again, if it's a disease process, the concept of getting the fluid out of the pericardium probably not going to come into play because you've got the infection on the inside. The pericardium is intact, so there's really, when you stretch that heart out, there's really nowhere for that fluid to go, okay? So it's not going to work as well as if it comes up from a medical condition. But what you can do is that if you give this fluid, you can get some of the blood out long enough for the patient to remain perfused and get to the hospital. Colin.
We're considering a fluid bolus. Are we looking at like a low systolic or are we looking at just a low blood pressure?
Just ask your question again because I don't think I understand it.
When considering a fluid bolus, you said a low blood pressure. Are we just looking at like the systolic, like below 90, or are we looking at if they have a pulse pressure like 80?
Short answer is yes. So keep in mind that, there's actually three things that you've got to take into consideration here for your patient. Obviously, we're looking at their blood pressure, okay? And then what we want to do is we want to consider what the map is, and that gives us a lot of information. But by determining the pulse pressure, it tells us whether our patient is getting better or worse. So you take all three of those into consideration as far as you're treating your patient. Does that make sense? Kind of, sort of? Okay. And so that's kind of the route that you want to go for these particular patients. Now, the other thing that you might want to do is consider giving a vasopressor. Now, those of you that are in 225, we talked a little bit about dopamine, and we talked a little bit about some of the dosing ranges of dopamine and the actions that it has, because it works on different parts of the body depending upon how much or how little you're giving. All right. I know dopamine is falling out of favor in practice. You still need to know about it because I want you to pass your exam. Okay, so let's talk about dopamine first, and then we'll go over the current practice. How much dopamine would you give in order to increase the contractile force of the heart? That's your whole range. That's your whole range. Now, Landon, do you remember what I said about dopamine as far as when does it affect the heart, in particular inotropy, and when does it now affect the alpha receptors of the peripheral vasculature? Okay, that's in the range, but that is one dose. But there's a range, and the range is going to be for dopamine. If you give 2 to 10, it's primarily going to affect inotropy of the heart. Now, with dopamine, typically we're always going to start out at about 5 mics per milligram or mics per kilogram per minute. Okay, and so that's going to get us within that range. But if we can stay within that 2 to 10 mics per kilogram per minute, primarily what we're looking at is that we're going to also, in addition to the fluid bolus that we're giving our patient, we're going to increase the snapback of the heart, the inotropy of the heart, that is going to help to increase cardiac output. Now, dopamine's not going to do anything as far in trauma about getting the blood between the pericardium and the epicardium. But what it can do is it increases the contractility of the heart to increase the blood pressure. The other thing that comes into play here is that when we give our patient dopamine and we go up above 10, now it doesn't affect the heart nearly as much. The effect on the heart begins to drop, and now it begins to affect the peripheral vasculature by activating the alpha receptors. Okay, and we have more than just alpha 1 receptors and beta 1, beta 2, but those are the ones that you and I are going to be most concerned about. One other thing about dopamine that you need to really know, and we'll talk more about some drugs in this class before the end of the semester, as well as next semester. If you give less than 2 mics per kilogram per minute, what happens to your patient? Very good. You dilate the renal artery, blood pressure drops. Okay. If you had a patient that's in acute renal failure, that's exactly what you want to do. You want to open up that renal artery, and most of the time you guys will come into contact with patients in renal failure, acute renal failure, because of things like burns, rhabdomyolysis, crush injuries, and things along that line. So give them just a very, very small dose of dopamine, pops that renal artery open, and flushes the kidneys out really, really well. Any question? Now, the definitive treatment for cardiac tamponade is 2 things. Number 1, short term, getting the fluid off of the heart. At one point in time, Kansas was the only state that I was aware of that was allowed to do what's called a pericardial centesis. Basically, you take a spinal needle about that long, you have a specialized alligator clip. Alligator clip is one of those clips that's really long, kind of looks like the snout of an alligator that we use in some electrical functions, and you connected it to your EKG monitor, okay, by snapping it into one of the leads. You put that alligator clip at the base of your needle, and there's several different approaches you can do, but remember, left ventricle is the one that's most affected. We would go up, when I worked in Kansas, we were allowed, I never have done this, we'd go up subxiphoid process, go up underneath the xiphoid process, go very slowly, watching both the patient and the monitor, and when we saw a sudden jump on the cardiac monitor, that tells us that we've made contact with the myocardium. Why? Because that's where the electricity comes through. We would back out just a little bit and then begin to pull pressure on the syringe. And the blood would typically begin to come out of, not of the ventricle, but out of the pericardial space. Nobody's allowed to do that anymore. It's extremely low incidence and extremely risky. So that'll be laid off to the ER doctor or potentially the surgeon. The ultimate treatment is that they're going to have to go in and seal up and either cauterize or surgically suture up whatever's causing the bleeding once you get them to the trauma center. Any questions on cardiac tamponade? Okay. Hypertensive emergencies. Basically, hypertension is a chronic disease that in many situations people don't know they have until they have an emergency. And an emergency could be anywhere from just having a simple syncopal episode to having some type of a stroke, either hemorrhagic and or an ischemic stroke that comes into place. Generally, what we're looking at here, especially with chronic hypertension, is slow destruction of the body's organs. In particular, eyes, heart, brain, and kidneys. The vasculature begins to constrict so tight, and in accompany with that, typically because of the Western diet, we have very decreased lumen size that now reduces the size of the diameter of the artery even more, so that we have less and less blood that is flowing through, leading to hypoxia of the tissue and ultimately coming about as a result, or ultimately resulting in death of that particular organ. Now, as far as like a preview of coming attractions for next semester in 305, understand that it can also occur as a result of preeclampsia or full-blown eclampsia, right? The big thing that we're seeing with patients that have preeclampsia is that their pressure is going to be up, they're going to have vision changes, and they're going to be spilling protein into their urine. Now, the protein that's in the patient's urine is directly related to their blood pressure. Why would that be? Why would high blood pressure, Landon, cause, in particular, OB patients to spill out protein? We can see this in males, especially if they have long-term hypertension, but what's the connection? Okay, I don't know. It's okay. What else? Anybody else? Give me a speculate on it.
Like damage to the glomerulars or whatever.
Mm-hmm.
It doesn't filter protein out, so it just dumps it.
Yeah, you're exactly right. Keep in mind, remember what did I say? Damage to the kidneys from hypertension is very, very common. We see this quite often in disease with diabetics. And so that's one of the big issues that people want. It's kind of got to control your blood sugar so that we don't destroy your kidneys. And so, Lewis, you're exactly right. Eventually, we begin to get cells that begin to rupture. And again, the tissue of the organs is very high in protein. And so the kidneys themselves now begin to not be able to filter the protein out, and it just dumps it out into the urine. That's often one of the earliest indicators that your patient has some type of renal failure that's going on, and that all comes about as a result of their hypertension. Now, high blood pressure is defined as any blood pressure taken 3 times in 1 week over a course of 7 days, where it consistently remains above 140/90, okay? Now, again, like I said, ischemic strokes and hemorrhagic strokes can come about as a result of hypertension. The good news is, guys, is that it's about 80 to 85% of the strokes are ischemic strokes. Those can be treated. Hemorrhagic strokes cannot be treated, okay? Pardon? Yeah, and typically what's happening, and depending upon where the bleeding vessel is, Devin, the risk of going in and opening up a patient's brain is usually going to be much higher than just leaving it alone and hoping that it clots off by itself. And so that's kind of one of the things that we look at. But again, and we'll talk about strokes here in just a little while as far as what you're going to see and what you're going to do and take care of it. So for you, the big thing that we're going to do is we want to provide rapid, safe, and quiet treatment to the hospital. Now, Benin, why would we want quiet transport to the hospital of a patient that's having a hypertensive emergency? Because if they freak out, what's going to happen to their blood pressure? Yeah, yeah. So basically, we're just making a bad situation worse. And so, Miriam, as we're looking at this, we want to be very confident. And again, this goes to the whole way that you present yourself and your ambulance to your patient. If you have a nice, clean ambulance, if you're in a nice, clean uniform, and you're polite and you're professional, that instills confidence from the patient into you, and it reduces their stress level. When we reduce the stress level, we reduce the blood pressure, and it can literally keep your patient from having a stroke. Watch your patient for the potential of vomiting. One of the very common things that happens when patients have really high blood pressures. Now, when I say high blood pressures, I'm talking systolics above 200, is that these patients will begin to vomit. They'll also complain, Rehana, of really, really bad headaches. Now, this is a key indicator for us that we've got a problem going on here. And we'll talk more about hemorrhagic strokes a little bit later. But again, remember, one of the signs and symptoms that we're going to see with our patients that have hemorrhagic strokes, Noha, is that we will have a sudden onset of what the patient describes as, this is the worst headache I've ever had in my entire life, okay? Your patient with a hypertensive emergency, Ryan, may simply tell you the exact same thing. But usually what they'll do is they'll say, oh, it's been getting worse for the last 12 hours. It's a gradual slope up with a hypertensive emergency, as opposed to for a hemorrhagic stroke. It's kind of like, oh, I was doing fine. Oh my gosh, I can't move. My head is hurting so bad. And it's an instantaneous type of thing that comes on in here. Do we want to give these patients oxygen? Say it again. You're starting to sound like me. Depends on what? Okay. Same criteria comes into play here with the brain as what we discussed about with the heart. What's two negative side effects of unnecessary oxygen usage? Said, I can't hear today. Nitrogen washout and free radicals, okay? Guess what, guys? Same thing with your patients that are having hypertensive emergencies. This is, in particular, we're really concerned about any organ in the body being negatively impacted and affected from patients that are having hypertensive emergencies. But in particular, in the short term, we don't want our patient to rupture an artery in here, because it can lead into a hemorrhagic stroke. So if your patient meets the criteria, the exact same criteria as what we discussed for cardiac disease in ACS, that's when you give oxygen. Number one, SpO2 of less than 94%. Number two, they look like they're having trouble breathing regardless of what their SpO2 is. And number three, regardless of number one, regardless of number two, if they look at you, Rehan, and they say, I just can't catch my breath, we're going to give them oxygen. Start with the lowest appropriate amount and then work your way up from there. Get your IV started. In many situations, what you're going to do in this particular situation is you're going to start a saline lock, okay? And because they don't need fluid. You got a blood pressure of 220 over 140, Landon. The last thing we want to do is to give them anything that's going to raise that blood pressure up even higher. If you are working with patients that are pregnant, how should we transport them? Why, Colin? It does have something to do with being pregnant. Clamping off what? It is a vein. You are right. Okay. So here, say it again. Which one? You got two. Inferior. Yeah. Please don't say superior because you don't get. I guess this is where pregnancy starts. So I guess that could be true, but you don't get pregnant in your brain. So yeah, you're exactly right. So the fetus is growing, and we see this in late-term pregnancies where the fetus is pretty much well developed. Generally, fetus is going to weigh somewhere around 7 pounds. You have amniotic fluid that can add as much as 5 more pounds. You have additional fluid or additional blood that goes into the uterus and the placenta that can add as much as another 5 pounds. So you're literally looking at potentially 20 or 25 pounds laying flat on the vena cava. The vena cava, inferior vena cava, is very floppy. It's not like the aorta that's really, really muscular. You lay your patient flat and you're going to take care of their blood pressure okay. It's going to plummet, and by the time you get them to the hospital, they're going to be in shock. So flip them over to their left, okay? If I would bring the blood pressure down, but we have no control of how quick it comes down, and if you got a blood pressure, let's say of 180 over 160, in a matter of about 15 minutes, now it's down to 120 over 80, you may think, hey, I did a good job. And what happens? Minna, what were you going to say? Generally, and that's called Trendelenburg. We generally don't use Trendelenburg anymore for a number of reasons. We don't do it in trauma patients because it manipulates the spine. All other patients, and in particular patients that you may suspect from a cardiac perspective or otherwise that have an altered mental status, we don't do that because it increases the pressure on the stomach, which at a certain point, if the pressure in the stomach gets too large, guess what's happening? Blech. And now we've got an airway issue.
Wasn't the original idea for that was like, while their blood's not circulating, so if you elevate their feet, then it's going to go back to the heart. Wasn't the research like there was no really that big of a difference?
No, it's junk research. It doesn't work. It doesn't work that way at all. And so it's much more dangerous in doing that. So, Bill, to finish up your question, and Colin did a good job as far as telling them, if our patient's blood pressure drops too fast, they're going to have a stroke. And so generally what's going to happen, not necessarily with the preeclamptic patient, but let's talk about the 70-year-old with chronic hypertension. They're going to put them on most likely some type of an IV beta blocker or calcium channel blocker, and they're going to bring that blood pressure down slowly over the next 12 to 24 hours. Now, we can give the patient some medicine. You'll carry beta blockers. You may carry calcium channel. What's that?
That's what I was asking. I was wondering if we could give those. Like, if we can give them slowly, are we allowed to bring it down?
It depends upon your protocol. Now, if your protocol aligns with the hospital in the fact that you're starting the beta blocker, you're giving it IV, and you're bringing it down slowly, then absolutely you sure can. And we'll talk about some beta blockers in here as well. Not quite to the depth and degree of what we're doing in 225. And by the way, any of you that are in the sequence for next semester, I would, if you haven't taken 225, I'd strongly encourage you to do so because it will get you ready really, really well for future exams as well as for your registry exam, because we go way, way deeper than what we have time to do in here. So if you've got IV beta blockers, you've got IV calcium channel blockers, then yes. If the medicine that you're carrying is only oral, so for example, after an MI, standard of care now is to start your patient on a beta blocker to reduce inotropy and to reduce chronotropy. Usually that's given orally. Now that's a no-go because we can't control how fast that blood pressure drops, and we don't want to cause our patient to have a stroke. Any questions about hypertensive emergencies? All right. Cardiogenic shock. Basically, if your patients go into cardiogenic shock, survival out of cardiogenic shock is not very promising. It is the most severe form of pump failure that we can see in the heart. We can have pump failure because of a problem with preload. We can have pump failure with a problem of the valves not working correctly. We have pump failure because we've lost a critical mass of the myocardium, then that is going to be a problem that can't really be fixed. All that we're able to do is to try to maintain function for our patient, and then they'll eventually, number one, either be considered for a heart transplant, depending upon their age and other types of situations that's going on, or that's just the way that they're going to have to live until they die. Basically, cardiogenic shock says that the heart, and in particular the left ventricle, no longer pumps effectively enough to meet the metabolic needs of the heart. Now remember, when we're talking about metabolic needs of the body, not just the heart, but of the heart, yes, but of the body in general. When we're talking about metabolic needs, we're talking about oxygen delivery, glucose delivery, and waste product removal, okay? The biggest waste product that we're concerned about right here is CO2 that can be utilized to be converted into lactic acid and other types of acid as a waste product as well. Most of the time, probably about 80 to 85% of the time, cardiogenic shock comes about as a result of an MI in the left ventricle, okay? Now, early on in cardiogenic shock, the body will do its best to try to compensate for the decreasing cardiac output by increasing contractile force, inotropy, as well as the heart rate, chronotropy. Why is this a compensatory mechanism of the heart? Why is it a bad thing for the heart? Yeah, both you gentlemen are correct. Basically, it speeds up the process of there's not enough resources in the way of glucose and oxygen being shared. And so as the heart works harder, more and more of the heart begins to die off. And so generally what you and I are going to try to do is try to keep a patient alive long enough to get to the hospital so that they can supplement the heart, usually by giving medications that will help to increase the contractile force of the heart without the degree of severe impact on the workload. Now, as we're looking at this, your patient will generally present with signs and symptoms of shock. They will just look sick, Muna. I mean, they'll have low blood pressure, they'll have a rapid heart rate, they may be pale early on. Now remember, if your patient becomes cyanotic, that's a late sign, okay? That's often a terminal sign for your cardiac patient. If cardiogenic shock is left untreated, giving them a fluid bolus and trying to enact Starling's law will begin to fail and your patient dies. So what we see here is cardiogenic shock that comes along, particularly with an acute onset, will be with patients that will have sudden chest pain as a result of an MI. They will begin to also have severe respiratory distress. These are two things that go together in cardiogenic shock. It is possible to have chest pain or to have an MI and have a serious MI disease with no respiratory distress at all. September, When I had my heart attack, I had really bad chest pain. I thought it was indigestion, goofy me, but I had no respiratory distress whatsoever, none, zero. Got over to the hospital, my SpO2 was like 98, 99%. And so that's a good thing when your patient presents like that, because that tells you what, Rihanna? If you got patients having chest pain, no shortness of breath, what can you gather from that information? Yeah. So the left ventricle is still pumping strong enough to get oxygen around to the body, and in particular back to the heart itself. As it progresses, know how your patient may now begin to have an altered mental status. And again, remember, cardiac patients will often have this impending sense of doom. That is a type of altered mental status. That's all because they're not getting enough oxygenated blood that's going to into the brain. So how much of the left ventricle can your patient lose and still not go into cardiogenic shock? As an average, what were you saying? As an average, about 40%. When your patient goes beyond 40%, now the contractile force of the heart is insufficient to meet the needs, and your patient begins to suffer from that. Your patient will often have both left-sided and right-sided heart failure, which would lead into the potential for JVDs, as well as pedal edema. And again, just as a reminder, if your patient's bedbound, and many of your cardiogenic shock patients will be, look in the small of their back, in the lumbar area, for any type of pulses or any type of edema. Basically, what we do is if you get called to a house and you've got a patient that is suffering from cardiogenic shock, our treatment is going to be supportive and to try to keep the pressure up high enough to get them into the hospital. Depending upon what would determine whether or not we would use CPAP in a patient with left heart failure and potentially in cardiogenic shock. Okay, lung sounds and blood pressure. We hear crackles, that automatically says, may put our patient on CPAP. We take a blood pressure is 90/60, and we go, probably better not, okay? It's kind of like that whole thing that we talked about as far as absolute and relative contraindications for nitroglycerin, all right? Let all the information that you see from your patient guide you. Colin.
You said the survival rate for this is not very good. It makes sense. So is there a code, is there a rhythm that they typically go into? And then what any of the ACLS?
PEA, you will often see patients deteriorate into that rather than going into VFib or pulseless V-tach because most of the heart is gone. And so the heart itself is trying to do its best to get electricity through, but there's not enough left for mechanical action. Good question. Again, we'll talk about push-dose epi a little bit later. Understand that you're going to want to start dopamine on these particular patients, especially at the 2 to 10 dosing range because of the inotropic action on your patient, okay? We're going to stop there because the next slide is going to be talking about push-dose epi, and I don't want to get into that just yet until we'll have enough time to do it. See, late in the day, you guys are looking brain dead. It's Thursday. So I'm going to stop us right there.